Okay, tonight we have Dr. Nader Hanna from Maryland in the States joining us for the third time. Thank you, Dr. Nader, for joining us, and the floor is yours.
Great. Thank you very much, Hisham. It's quite an honor. As Hisham pointed out, this is my third time over the past couple of years. Thank you for that kind of invitation. I'll make it informal, so if anybody has questions during the lecture, feel free to raise your hand or ask the question, or we can delay it towards the end. It will be your choice. So we're going to talk about multivisceral resection for colon cancer. So we're not talking about metastatic disease. And before I start, I have no financial disclosure, and this is my presentation. So what are we talking about when we talk about multivisceral resection for colon cancer? So clinically, we're talking about clinical T4 MX M0. So this is, you get a CAT scan, you see a tumor clearly originating from the colon and involving adjacent structure, but no evidence of metastatic disease. Quite frequently, the nodal status is unknown. You can see some enlarged node, but these patients have no metastatic disease. So we're clinically talking about T4 when there's evidence that the tumor is invading or adherent to other adjacent organs. And pathologically, this is response to T4A, which is tumor adherent, but not invading into adjacent structure, or T4B, that's when there is actual invasion of the tumor into adjacent structure, as you see here in this pathological slide, where you can see colonic adenocarcinoma here, and you can see this tumor. This is actually this cut from this patient, where you can see the colonic cancer is invading into the skeletal muscle or abdominal wall. So this is a case of a T4B invasion into the abdominal wall. So what are the clinical issues that you need to know about when you're dealing with clinical T4, pathological T4A and B? The incidence of this condition clinically in about 10% of all resected cases of colon cancer. And again, we're only talking about colon cancer. We're not talking about rectal cancer. It's a different category. So it's about 10% of all resected cases will be proven to be on T4, clinically advanced cases. When you're doing an emergency colectomy, the incidence is about 69% of those patients with T4 are going to be in emergency cases versus only 26% in elective cases. These patients tend to have a higher positive margin because of the bulkiness of the tumor. And these tumors tend to be biologically more aggressive, meaning the majority of them have a higher proportion of MSI high tumor, and they tend to have a poor histological grade. They tend to be actually a mucinous tumor. We know that T4 have one of the highest risk for peritoneal carcinomatosis. This was a cohort study of over 11,000 patients with colorectal cancer, and they looked at the various prognostic factor or independent predictors of subsequent developing peritoneal carcinomatosis. And you can see that one of the highest risk was the highest hazard ratio for developing peritoneal carcinomatosis. Actually, was T4 was a hazard ratio of 9.98, was a p-value quite significant. Other significant independent predictors, N2 was less than 12 nodes examined, R2 resection when you're leaving tumor behind, right-sided tumor, and emergency operation. Usually reflects either obstructive tumor, perforated, or again, clinically T4 lesions. So these are the lesions where have a high likelihood of the risk of developing peritoneal carcinomatosis. In fact, this was a study done in 2020, published in 2020, where they looked at 125 patients with T4, and at a median follow-up of 3.7 years, the overall rate of peritoneal carcinomatosis was approximately 35%. That means 1 out of 3 patients will actually end by developing peritoneal carcinomatosis. This was found at the time of principal operation or diagnosis or synchronous in about 12% of cases, and subsequent patient developed carcinomatosis or metachronous carcinomatosis in about 1 out of 4 patients, or about roughly 23% or so. So clearly T4 is associated with much higher risk for developing peritoneal carcinomatosis. So what's the clinical evaluation? So if you look at whether you're doing a CT scan or a PET CT scan, the accuracy is not very high. Sensitivity is again also low, but they are more quite specific when you have a patient with clinical T4. In fact, if you look at in the randomized preliminary Foxtrot trial, I'm going to tell you about this trial pretty soon, they found that only 47% of the radiologically assessed T4, what's that mean? Mean when you have an X-ray, a scan, a CT scan with IV contrast at least, when the radiologist called the tumor as a T4, about 47% of patients are only confirmed histologically to be T4. So there is a tendency of overstating the T4 lesion, just to keep in mind. Now, what's the Foxtrot trial? The Foxtrot trial, and it's going to come again in the lecture, is a randomized trial looking for whether neoadjuvant chemotherapy on T4 lesion, clinical T4 cases would actually provide any survival advantage. So I'm going to come back about the Foxtrot trial in the next few slides. But the whole purpose of doing the scan is also to exclude metastatic disease, because that will change the algorithm of the surgical intervention. In fact, you would consider neoadjuvant chemotherapy provided the patient does not have obstruction or perforation. But also, it's really identified the need for multivisceral resection, especially when demanding surgical procedure may be required. Examples of that, when there's tumor invasion into the bladder, the ureter, or the kidney, where you're going to have to do some urological resection at the same time. But most readily is when you need to do a Whipple procedure or a major vaginal resection, because these are demanding and obviously have a higher rate of complication. But as many of you have done many of these cases, you know for a fact that in many cases, the decision for multivisceral resection is really, really determined by the intraoperative finding. Remember, we said the X-rays, the best X-rays we have, whether it's the CT scan, MRI, or PET CT, can only accurately diagnose it in about 47% of cases. Now, what are the principles of surgical management? So if you look at the NCI guidelines, if you have a patient who you suspect that they have clinical T4 lesion, and in non-emergent cases, their standard recommendation in the United States is to consider neoadjuvant chemotherapy, particularly FOLFOX or CAPOX. And again, this is the principle of the randomized phase 3, the Foxtrot trial, which is currently ongoing and hopefully will be completed this year, and maybe some early reports in the next year or two. So this trial is currently going on. The major surgical principle is the en bloc resection of the continuous structures, whether it's attached adhesions or infiltration. Do not disrupt the plane of adhesion. About up to 84% of these adhesions are actually malignant, and there are a couple of studies that actually looked into that. In fact, this is an example of histological where there was a sigmoid cancer invading into the cecum. And you can see here in this slide, histological slide here, this is the mascularis propria, here's the subserosa, and this is the adjacent normal colonic mucosa. And you can see there's tumor infiltration into the adjacent colon. Okay, so you do not want to disrupt this adhesion. This is malignant adhesion. You actually want to resect both portion of the bowel. Okay, and if you look at the risk of doing that, so if you cut through this malignant adhesions, of course, it's hard to tell what's malignant adhesions or what's desmoplastic reaction. So if you end by finding this adhesion were malignant, and you'll have a positive margin, the risk of local recurrence can be up to 100%. There is about 20 to 25% risk of peritoneal carcinomatosis, and they have a very poor survival. 5 years is anywhere between 0 to 30%. And this patient quite frequently don't do too well. Remember, we said this tends to be biologically aggressive, mostly are mucinous tumor, and they have a higher percentage of MSI high tumor. So just be careful about trying to save that ureter or that piece of the bladder. You're actually, you know, you might look at you sound like you feel comfortable, you did a good operation by preserving that, but in fact, you're hurting the patient in the long term. This was actually a paper that was recently published a couple of years ago which looked at specifically the difference between the rate of peritoneal carcinomatosis when you have T4A and T4B. So they actually followed this patient, the T4A and T4B, for 5 years. And what you notice here, okay, what you notice that the 5-year peritoneal metastasis rate, okay, this was just published last year, for T4A was 24.7% versus 12.2% for T4B. So it's almost twice. So the risk of peritoneal carcinomatosis in T4A is as twice. Why? Most likely because the surgeon thought he was doing a patient a favor by dissecting the tumor of adjacent structure. So please do not dissect adjacent structure, but you need to resect those structures. Following on the principles of surgical management, when you have a distal lesion in the sigmoid or descending colon, you need to consider stenting. And this one will have several advantages. First of all, it allows you to prep the colon to do primary anastomosis if you end up by resecting the patient. But again, if this was a T4 lesion based on the NCEA guidelines, you should give this patient the benefit and giving them the adjuvant chemotherapy. So the standard for us here, if you have a distal lesion, you can certainly stent. We have advanced GI service, which will stent virtually any lesion as long as they can pass a small guide wire, and then they can put a stent and expand the colon. And actually the patients do quite well with that. So if that's an option that's available for distal lesions, it's a good bridge for elective resection, primary anastomosis, avoiding a bag, but also allow the patient to get the recommended neoadjuvant chemotherapy. Minimally invasive surgical approaches, if oncological resection is feasible, you can do it if you're experienced. You have had really great volume of MIS approach to do that, but be prepared and do not hesitate to convert an open case. There is no triumph of trying to do this case laparoscopic or robotic, because the patient will pay the price a few years down the line because of the high risk of carcinomatosis if you do not do the oncological dissection. So while there is no contraindication to minimally invasive surgical approach, it's probably not very wise to do that unless you're very experienced. And again, depends on what you're talking about. So if you're talking about, partial, dome of the bladder resection, sure, you could do that. But, probably, of course, they will never do Whipple laparoscopic in a face of a T4 lesion, and certainly other major hepatic resection for continuous invasion. And I'll show you a case, probably not appropriate for that minimally invasive approach. Now, if you anticipate you're going to need postoperative radiation, especially tumors invading into the abdominal wall, it's a good idea to place a surgical clip at the margin, so it would be a target for the radiation oncologist to kind of know exactly the target area, which maximize the benefit of the radiation. On certain areas, if you can exclude the small bowel from the field, that would be quite advantageous, because that will protect the small bowel from the dose of radiation that normally would be given. And the way to do that, you can do a mental flap or sling, or you can put spacer. I can tell you what we have done in the past. You can use actually saline implant, breast implant. You can fill a space between where you think you need the radiation and to displace the small bowel. And they are easy to come out afterward. So you can do a saline implant that you use for breast, and if it comes in different sizes, you can do that to isolate the small bowel. If you anticipate, there's a need for radiation postoperatively. In this picture here, you can see the sigmoid obstructing sigmoid cancer. This was actually invading into the ureter, and we ended by resecting the distal ureter as well. So let's talk about specific organ invasion. So the denal invasion, because this seems to be quite difficult somehow to have to manage. So if you can see here in the image, it's clearly this is a D2. This is the colon here, and you can see there's tumor extending, invading into the D2, D3 area right here, okay? So you can see clearly that. So what are the options? The options is you can, of course, you would resect that part of the duodenum, and depending on the defect of the size of the defect as well as the location, you can either primarily closure in transverse fashion to avoid stricture, You can do a serosal jejunal patch with their hair, but one quite frequently forgotten approach is the mucosal jejunal patch, which I'm going to explain to you. But this is the one that a lot of people don't think about, have never done it, and probably have never read about it quite a lot. But I'll show you how it's done. It's quite easy, especially when you have a large defect in the duodenal wall. So this, if you look at here, what do we actually do? So it's actually this case here, and we'll start at top A. You can see this is the tumor where it's adherent, obviously, to D2, D3 area. This is the area, you can see the defect and the duodenum after we resected it. After it was resected, you can see the defect is quite long. So what you do is actually, you isolate, for those who do ileal conduit is very similar. So you isolate a loop of jejunum, which would have a good blood supply that's redundant, and you bring it out all the way up to the duodenum. And then what you do is you open the anti-mesenteric border of the bowel. So here's the bowel completely open in figure E. And this piece of bowel is maintained with an excellent blood supply from the mesentery of the small bowel. And then what you do is you place it over that defect and you kind of suture it circumferentially. So it gives you quite a bit of white lumen, and it's a well vascularized patch, and it's very effective and eliminates the need for doing an emergency or Whipple procedure during colon resection for a T4 lesion. So just remember, this approach is quite easy. When you do it, it really looks good, and they heal very well because it's well vascularized. The key thing is, again, you need to maintain a segment of jejunum that has a good blood supply, tend to be proximal, and it's no different from when you're bringing jejunum to do procedures. You can easily come usually the transverse colon is gone, so there's not much in the way of bringing the loop of jejunum to the duodenum to do this mucosa patch as well. So next time you're faced with, well, how am I going to manage this big defect in the duodenum, think about the mucosal jejunal patch. How about for D3 and D4? Usually we do segmental duodenal resection, and you can see here, this is transverse colon cancer. You can see the cancer is quite large, and you can see tumor extending into D3 right here. Now what we do here, you just identify the ampulla, and you just divide the duodenum essentially distal to that, and you take the ligament of Trice, like when you're mobilizing that fourth portion of the duodenum during the Whipple procedure, and then you bring the loop of jejunum and you divide that. So how do you identify the ampulla? You can open the duodenum distally and just see where the bile is coming from, or quite easy as well, you can take the gallbladder out and you can put a catheter, Fogarty catheter or a small red rubber catheter through that, through the cystic duct into the common duct and then through the ampulla, and it exactly tells you where is your ampulla and whether your surgical margin is adequate or not. So for D3 and D4, segmental duodenal resection with duodenal jejunostomy, primary anastomosis should be quite feasible and adequate. How about if you do Whipple procedure? This is the, by the way, this is the same case, but you're looking at an axial, and you can see, again, tumor extending here from the transverse colon tumor right into the D3 as well. Can you do a Whipple procedure? Well, yes, you can. It does provide a chance of, cure with better prognosis than doing just palliation, because if you leave the tumor behind, the natural history of the disease is quite short and the patient do well. There were several publications. However, you just need to be aware that, of course, there is selection bias. So when people publish, their outcome of doing a Whipple for, tumor penetrating into the head of the pancreas, they are highly selective and probably the patient has excellent performance status. Certainly the risk of complication after that is pretty high. Now, so the issue was doing a Whipple is different for colon cancer. Invasion is different from doing a Whipple for pancreatic cancer. The reason was pancreatic cancer, the pancreas tend to be firm, the pancreatic duct and the bile duct tend to be dilated from the chronic obstruction. stitches tend to hold better. So with Whipple for pancreatic cancer, the difficulty is in the resection because of the vascular and potential for vascular invasion. Reconstruction tend to be easier. When you're doing a Whipple for a trauma, for example, or in these cases, the pancreas is soft, the pancreatic duct and the common duct are very small, they're very thin walled. So dissection tends to be very easy. That's what people, are kind of misled. Oh, it's going to be an easy operation. Well, yes, it is. Actually, it's easier than doing a Whipple for pancreatic cancer, but the problem is the reconstruction. The pancreas is soft. The tissues are very, thin and non-dilated ducts. The stitches don't hold well. And the majority of this patient by far will have some form of a pancreatic bleed, which certainly can affect your stomach suture line when you're doing transverse colon resection in the primary anastomosis. Just be conscious, and obviously the patient performance status and nutritional status are absolutely important from the decision-making process. Now, this is a tumor where this tumor was in the distal transverse colon. You can see it's invading the body of the pancreas, the spleen. These ones are easy. You just go ahead and resect the distal pancreas and spleen. And you can see it here. You can see the tumor is actually extending almost at the splenic flexure, invading into the spleen right here. And you can see also that you can see the colonic adenocarcinoma here, and it's invading into the pancreas. So you can see the histological actual invasion. Trying to save the distal pancreas, I think of no value at all to the patient from the oncological point of view. And this is T4B transverse colon adenocarcinoma that was clearly invading into the pancreas. How about for the liver? So this is actually a patient, it was back in January of this year. And you can see here, this is a liver right here, right? And you can see the transverse colon here, and you can see portion of the left lobe of the liver here. So you have liver here, and the colon right here. What you don't know about this patient, this was actually a transplanted liver. So this was not a native liver of the patient. This was a transplanted liver. Of course, the tumor was obstructing, there was necrosis, and clearly we knew this was a T4 lesion, which actually appears to also be invading the abdominal wall. But this one, you cannot put a stent, you cannot bypass, and there's evidence of perforation, so we had to take the patient to the operating room. You can see here the transplanted liver is right here. And the issue was this tumor was invading right here into, unfortunately, the hepatic hilum and the portal structure. So the only way to take this out is you would have to take the transplanted liver out. And clearly we were not going to do that in this emergency situation. So unfortunately we had to abort the case and do a diverting ostomy and treat the patient with chemotherapy. Very doubtful that this patient will come to surgery, exploring the hepatic hilum after a liver transplant is just a dreaded operation to do. But especially this transplanted liver was about 3 years ago. So it was well scarred then. So this is, again, not every case is happy ending, but this is one of the unfortunate cases. And always when you give a talk, you should also just not talk about success and triumphs, but also need to talk about your failures and when you are unable to really help the patient. This is a tumor in the sigmoid cancer, the sigmoid colon, sigmoid cancer. You can see it's clearly invading into the bladder here. And we can see here, this is the specimen when we took it out. And you can see there's clear fistula into the bladder from the sigmoid cancer. And you can see it right there. So do not hesitate. Now, this was extensive cancer extending into the insertion of the ureter. So we actually had to do a total cystectomy and ileocondylar. You can see the ureter right here. So this was a major, combined, colon resection and bladder resection as well. You can see the specimen is quite clear. Okay. So that begs the question, is there a role for prophylactic Hypec in this situation? Now, and places where we do the Hypec, we do have the ability to do Hypec right away if we need to. We have the equipment, we have the chemotherapy available, but is it the right thing to do? Well, The answer was that was provided by the Polypec trial, which is the trial about prophylactic or adjuvant Hypec, where now the criticism for this trial is that they used oxaliplatin for 16 minutes at 40 to 42 degrees Celsius. So this is not the standard chemotherapy that we use in the US or most of the world would use. If you're going to use oxaliplatin, 60 minutes does nothing. So it was really a lot of criticism. And there's also criticism about, the patients, how they followed. And while the study showed there was no improvement in peritoneal metastasis-free survival at 18 months, the relapse rate was 19% in the Hypec arm and 23% in the control arm, non-statistically significant. However, if you look carefully at the clinical trial and the patient assignment, and when you analyze patients who were actually taken to do Hypec and T4 lesion, you'll find that actually it seems that prophylactic Hypec provided benefit in about 23% of the patient versus 10% actually in the patient who did not get the Hypec. So this trial has a lot of criticism, but nevertheless, it's out there, it's published, so this is what the data shows. Now, most people, because in the US, we can't do this without insurance billing, so very much so we don't do it because of that particular trial. However, there's another trial that's going on, and you probably in the conference that you guys are having in the next few days, you have a lot of people talking about cytoreductive surgery, including Sugar Baker. So he might give you some update about the Hypec T4 trial. This trial is ongoing. It's in Spain. And it's a multi-center randomized clinical trial. And the control arm is proactive tumor cytoreductive surgery plus appendectomy plus total omentectomy plus round hepatic ligament resection, as well as oophorectomy and post-menopausal women. So this is the standard arm. And so it's a debulking procedure. Remember, this is not metastatic, it's a T4. So we're not talking about carcinomatosis here. And they're resecting the appendix and the ovaries because they're a common site of metastasis, and also the omentum is a common site of metastasis. What's the experimental arm is the same as the control arm, but now they're doing mitomycin C, which is the standard intraperitoneal chemotherapy for colon cancer, for 16 minutes at 40 to 42 degrees Celsius. The criticism upfront for this trial is that mitomycin C is only used for 60 minutes rather than the standard 90 minutes. So most European countries and surgeons will do the Hypec only for 60 minutes. And the reason for that is just time spent in the operating room. In the United States, we always do 90 minutes, whether you're going to use oxaliplatin or mitomycin C. So upfront, there will be some criticism, but this trial actually seems to be better in terms of randomization, and the debulking is well defined. This trial has a completion date of October 2023, and probably we would not hear about it until 2025 when we have interim analysis. But at least there's an ongoing trial to see if prophylactic cytoreductive surgery and Hypec and T4 would provide any additional benefit. So you can do the operations. What are the surgical outcomes of those multivisceral resection? There is no randomized trials for this extensive procedure, but several published series of multivisceral resection which show that R0 resection can be achieved in 90% of cases. Certainly it requires surgical expertise and planning and good patient evaluation and management postoperatively. So in these cases, postoperative management is absolutely essential, and good postoperative management is a must, especially nutritional status in terms of supporting the recovery with this multivisceral organ resection. There is definitive but acceptable increase in morbidity and mortality in those demanding multivisceral resection. They are associated with increased operative time, which is no surprise. There is increased intraoperative bleeding, also no surprise, and perioperative transfusion, all granted and acknowledged with this operation. Similar survival to standard colon resection. These patients, when done with negative margin, their 5-year survival is very similar to if you would just do the colon resection alone. So what are the factors that affect postoperative morbidity and mortality in this patient? is actually the patient's general status and performance status and comorbid condition. So diabetics, heavy smoker, morbidly obese, of course, they don't do as well as healthier patients. Surgeon skill is important. This is not a one-man show. Quite frequently, we have urologists or we have some other folks that might be able to help, or even your colleague help you out. The two heads is better than one, okay? And of course, as you expect, the type and number of involved resected organs can lead to specific complications. For example, if you do total cystectomy with ileal conduit or urethral reconstruction or implantation, and of course, the most serious one by far would be a combined colon resection as well as a Whipple procedure. But nevertheless, the data seems to support if you can do it and you can do it right, you should do it. So this is looking, at following up patient who, if you look at this curve, the top curve right here, this is our T4 not locally advanced, meaning did not require multivisceral resection. Second line here, graph, this are locally advanced that required multivisceral resection. The bottom curve, this are locally advanced where the surgeon did not feel comfortable or no multivisceral resection was done. And you can see that there is difference in survival. So the message here, if you could do it safely, you have the technical ability, you have the support for post-operative care for this patient, it's not unreasonable to take these cases on. Preferably, there's a team approach. There's cases should and must be discussed in the multidisciplinary fashion and determine if the patient can have neoadjuvant chemotherapy before doing the multivisceral resection. That will increase your negative margin rate and perhaps organ preservation rate. Why is this important? So if you look at the survival data, the outcomes of T4 lesion. T4 lesion have poor prognosis in general. But if you look at here some of the discrepancies. So if you look at T4B and 0, which is stage 2C for colon cancer. Again, we're only talking about colon cancer. They have actually a 5-year survival worse than, see that 37% than stage 3A, which is T1, T2. Just tells you how bad is the prognosis, because even for node negative T4B lesion, okay, that stage 2C has worse prognosis than actually 3A and 3B, which is non-T4. And if you look at when you have T4A with node positive, okay, or T4B with N1-2 disease, of course, these people have worse prognosis. The worst just before stage 4 was only 28% 5-year survival. So you can understand why T4 lesion is a bad biologically case for the patient with a poor survival, whether it's a node negative or it's a node positive. The 5-year survival for node negative is only 37%. For node positive is 28%. So it's pretty bad, okay? So T4 here trumps the nodal involvement. So what is the, based on this recent evolving data, so the ASCO changed their guidelines in December of 2021 to the following, that they said T4 N0, that's stage 2 colon cancer, T4 N0, stage 2 colon cancer, should be offered chemotherapy, adjuvant chemotherapy, okay? This was not the standard recommendation prior to December 2021. The standard language before that was maybe, and so maybe is still present for patient stage 2 colon cancer who may be offered chemotherapy include specimens that have less than 12 lymph nodes. There is evidence of perineural or lymphovascular invasion. Patient was poorly or undifferentiated tumor grade. Patient was intestinal obstruction, tumor perforation, or grade budding tumor 3. These are patients who may be offered. The only time that should be offered is when you have T4B. So this is the most recent recommendation from the Journal of the Clinical Oncology from GCO. This was again published in 2021. So in summary, you need to consider neoadjuvant chemo in clinical T4B and non-emergency cases. Resect and block, not dissect, whether it's attached, adherent, or invading other organs. R0 achieved in 90% of cases, despite increased but acceptable postoperative morbidity and mortality and demanding multivisceral resection. There is improved local control and overall survival compared to palliative approaches only. Close follow-up for increased risk of peritoneal carcinomatosis and liver metastasis is absolutely important. And in very advanced cancer cases, above all, decisions are way more important than incision. What's that mean? The decision, first of all, the decision to operate, is it the right decision? Not every case you should operate on, even though you think you could do it. Don't think about just the surgery, think about the patient short and long-term prognosis. Okay, so if the patient can tolerate a stent and neoadjuvant chemotherapy, it's probably better for the patient. That's a more important decision to make than incision. And most advances in surgery is really not in the surgical techniques. It's really integration and timing of other modalities peri-operatively, meaning mostly before the operation. And that's why this case really should not be undertaken by just the decision of the surgeon. It's preferably when you have a multidisciplinary team with the radiologist and the GI folks, and as well as the medical oncology, are able to give you advice and recommendation of how they can help you do the operation, yet can maximize the benefit of the patient with a lower risk of recurrence and lower risk of metastatic disease. I think I'll stop right here, and I'll be happy to take any questions. Hisham, it's all yours.
Thank you, Dr. Nader. Please, if you have a question, raise your hand. Dr. Wael.
Thank you, Dr. Nader, for this very comprehensive and hands-on presentation, as usual. So if you allow me, I just two comments. The first one, as you mentioned earlier, that about 70% of cases with T4 locally advanced colonic cancer will come as an emergency setting. And 1 in 3 of them will have peritoneal carcinomatosis. So in case that intraoperatively found that there is solitary peritoneal carcinomatosis adherent to the or close to the area of the lesion. So would you go for cytoreductive adiperitonectomy for this one? Despite this is not within the consensus of the Polypec trial, because this is prophylactic with no peritoneal carcinomatosis. Shall you go for a cytoreductive adiperitonectomy with Hypec on these cases?
Well, great question. Obviously, you must have encountered this clinical scenario. So yes, the short answer is yes. So if you opened the patient, presumably it was non-metastatic T4 lesion, and you find carcinomatosis, absolutely. The standard, you're not going to close the patient. Remember, you're talking about urgent cases, so closing the patient is not going to help at this point. You're already, in the patient abdomen. So yes, we would resect and do resect the metastatic disease of the carcinomatosis. I would do total omentectomy. We would do appendectomy. We would, if this is a postmenopausal woman, even there's no obvious carcinomatosis, we would do bilateral salpingo-oophorectomy, and we do have the ability of doing Hypec at the same time. I think the difficulty or the issue would come, okay, what if this was in the middle of the night and you don't have the Hypec, you don't have the machine, you don't have the pharmacy to prepare your chemotherapy? Then what I would do the cytoreduction without Hypec, because this is the best you could do. You can do it later on. In these cases, what we do, we treat the patient with adjuvant chemotherapy, and then we would do a staging laparoscopy 6 months later. If we pick up recurrent carcinomatosis, then we can easier to do laparoscopic Hypec, or we could do open, whatever you prefer. But if you're in abdomen of the patient and you find carcinomatosis and you can resect it all, please do it. Now, if you find the carcinomatosis is extensive and this is the middle of the night and you don't have the chemotherapy options available, you can do something different. You can certainly do a diverting ostomy, give the patient chemotherapy, and then come back. we quite frequently, if it's a T4, what do? We actually do a diagnostic laparoscopy first because of that risk, knowing that, you know, 1/3 of the patient might have carcinomatosis. We do staging laparoscopy. If we find carcinomatosis, then we plan for elective the next day, you know, site reduction in Hypec, or consider chemotherapy and stenting of a distal lesion. The key thing is, if the patient has indication for neoadjuvant chemotherapy, please try to make it happen. Whether, you know, you're gonna use the staging laparoscopy up front, or you're doing a stent for distal obstruction, chemotherapy is important. The problem is, if you don't do the chemotherapy up front, as you know, about 47% of this patient will not come to get chemotherapy. And chemotherapy beyond 12 weeks is of no benefit. So if we have a patient with colon surgery and have complication and does not get the chemotherapy for 12 weeks, they do not get chemotherapy. Studies show there's no benefit. So that's the whole idea of trying to do the neoadjuvant. The Foxtrot trial, the one I mentioned, hopefully will guide us whether neoadjuvant chemotherapy really provided. You know, and there are 2 time points. So in cancer, we're now looking not just survival, but time to disease progression. And this is important for cancer like colon or breast, because we have continuous development of drugs. And, you know, we hear about immunotherapy in rectal cancer, where old patient who got the immunotherapy, the cancer completely went away. So there is, you know, rapid development for chemotherapeutic and immunotherapy for colon cancer. So just buying time is very important in this scenario. Well, great question.
Right. Thank you, Dr. Nader. And another comment, which is, if you have got a resection for T4, multivisceral resection for T4, and you have got a negative margin, you resected with negative margin, is there a role for adjuvant radiation therapy for those patients?
So if you have a negative margin, so negative margin is determined by 2 things. One, of course, pathology, but also you as a surgeon, you have to have your gut feeling. Do you feel like you really took it all out? You know, pathology take cuts in certain area. It depends on how much was involved with other organs. They're not gonna cut 4-centimeter invasion into adjacent structure. So if you feel, you know, especially if the field of radiation does not involve small bowel, so that abdominal wall, yeah, I will have no problem with a negative margin to consider radiation. You know, now it comes an issue in the retroperitoneum where you have the bowel and the blood vessels and nerves. Yes, if it's negative margin, probably even the radiation oncologist will be hesitant to give radiation and risk, you know, radiation enteritis, which is quite a miserable problem when it happens. So it's a clinical judgment and histology. Certainly, if the histology is negative, that gives you more comfort not to use it.
Thank you.
We have another question from Dr. Ahmed Ismail.
Sure.
Please, if you have any question, raise your hand. Yes, please go ahead. Yes, go ahead.
Thank you, Dr. Nader, for your presentation. Thanks, Dr. Hisham, for your effort. I would like to ask Dr. Nader about the safety of use of SIMS, self-expanding metal stent, in locally advanced obstructed cancer. We know that SIMS carry complication rate, perforation or migration up to 10%, especially after melting of the tumor with the neoadjuvant chemotherapy. So in irresectible tumors, obstructed, considered for neoadjuvant chemotherapy, isn't safer to do a temporary stoma instead of SIMS?
So putting the stent, as you know, is done by the GI. So it really depends on the expertise of the GI. Remember, when they put a stent, the stent it's hard to come out. There are techniques to get the stent out if you need to. Patient who has obstruction, you're talking specifically about the risk of perforation and bleeding with Avastin. So and those patients, depends again the clinical scenario, especially if the patient is hypertensive already, you might not want to include Avastin. But if you go to the neoadjuvant protocol that's recommended for this T4 lesion, does not include Avastin, because remember, these are not metastatic. So it's either FOLFOX or CAPOX as a neoadjuvant chemotherapy. That's particularly important that you do not use Avastin because of the risk of bowel perforation.
So you recommend SIMS over temporary stoma?
Yes, the whole purpose is the stent as a bridge was to do primary anastomosis with stoma. Now, if the GI folks gonna do it, you don't have experienced GI, certainly doing a stoma is actually a good practice to do. The key thing is if the patient needs the adjuvant chemotherapy, whatever it takes to make it happen, make it happen. Okay. Especially the advantage of, you can look at also the advantages. If you're going to do, especially if you're going to do it minimally invasive laparoscopic, that allows you to evaluate the peritoneum for metastatic disease because now you're changing from T4 M0 to M1 disease if you find carcinomatosis. That will change your algorithm completely and the surgical planning later on. So it's good to know and have the patient prepared for that.
Okay, we have another question from Walid.
Hi, Walid.
Yes. Hello, Dr. Nader. Thanks a lot for your marvelous presentation. I would like to ask you, would you consider also the same principle of multivisceral resection for a case of right colon cancer that underwent right hemicolectomy, then presented with an ovarian Krakenberg tumor in the form of a pelvic amalgamated mass, which is invading the sigmoid, bladder, and small bowel, also the uterus.
Right. So this is not multivisceral resection because multivisceral resection we're talking when you're dealing with primary tumor.
Okay.
So the original cecal cancer was a T4 or suspected to T4, as I said, in my standard practice, and as a common practice in the US, with T4 lesion is that we take out the ovaries in postmenopausal women and we do total omentectomy and appendectomy because these are common hidden site for carcinomatosis. Now, what the scenario you're describing is not really Krakenberg tumor. You can certainly could have started as Krakenberg tumor, but if you have tumor in the pelvis that's involving the ovaries, invading in the sigmoid colon, and probably the bladder has to be involved somewhere between, if this was a female patient, the bladder is right there. This patient might actually need pelvic exoneration, quite honestly. I don't know how you can get the significant involvement of the uterus and the sigmoid colon and the bladder. It's hard to justify, even if you're technically able to go below and you think you could do colorectal or coloanal vertinostomy, the risk of local recurrence is very high, and the patient would be miserable if they develop pelvic recurrence. I think in this case, we would certainly consider a permanent descendant colostomy rather than hooking him up and having a higher risk of disease recurrence, which is going to be invariable, happening at some point of time, and then it's unresectable. And doing a diverting colostomy at that stage would also be quite challenging and difficult for the patient.
Okay. Thank you.
You're welcome.
Do we have any other questions? Please, if you have a question, raise your hand. Okay, it looks like we don't have any more questions. And so thank you for joining us today, Dr. Nader. We really enjoyed the presentation and always looking forward to having you with us again in the future if you have the time.
Sure. Thank you very much, Sam. It's been a pleasure. Always an honor to kind of join you guys. Great conference every week. And it's awesome. And good luck with the conference coming in the next few days.
Thank you, Dr. Ned. And looking forward to seeing you in person, whether here or in the States or let's see.
Thank you, Sam.
Okay, thank you, Dr. Nader. Have a good night. And thank you everyone for joining us. And see you next week.
See you. Take care. Bye-bye.
Bye-bye.